Okay, now let's talk about potassium. Here's potassium from the diet. It's being absorbed across by the enterocytes. Potassium is obviously very important for cellular function, but it's also something that can be impacted by chronic kidney disease. So potassium, after it's absorbed, it's heavily regulated by the kidney. It's the main site of potassium excretion. A little bit is lost in the stool, but the majority of our potassium balance comes from regulation in the kidney, especially at the collecting duct at the side of the principal cell where there's a ROMK channel that's adjacent to the ENaC channel. And so, as you can imagine, in the setting of chronic kidney disease, if you have fewer nephrons doing that job, you'll have decreased potassium excretion, and so you'll be at risk for developing hyperkalemia. And so hyperkalemia is bad because potassium, especially extracellular potassium and intracellular potassium concentrations, determine the resting membrane potential for myocytes. And so hyperkalemia can be life-threatening, especially if it causes cardiac dysrhythmia. And so we do know that extremes of potassium concentrations are not good. They're associated with death and poor outcomes. So very low potassiums, but also very high potassiums. And so it's not uncommon to find hyperkalemia among our patients with chronic kidney disease. So there are a number of strategies to be used to manage hyperkalemia in a patient with CKD. First and foremost, a dietary potassium restriction is important. Many potassium-rich foods like fresh fruits and vegetables are healthy choices for patients, and they have high fiber and high vitamin content, but unfortunately they can contain high levels of potassium. So one thing I do in clinic, I print off sort of a patient-friendly list of high potassium foods, and we go through it together, and that way I can identify maybe one or two foods that they may be consuming too much of, and so we can talk about restricting or eliminating these foods from the diet. Next, if the patient has hypertension or edema that I need to manage anyway, I just make sure that I'm using a diuretic because that could enhance renal losses. Also, I screen the patient for constipation. If you think about it, reduced transit time through the gut will actually increase potassium absorption from enterocytes. But if we reduce that transit time, maybe treat constipation, we could increase stool losses of potassium and avoid hyperkalemia. There are a number of sort of these binder agents like SPS mixed with sorbitol, also known as K-exalate, and there are some newer ones that have come out, Petromer, and then this one that's called ZS9, that are used to actually bind up dietary potassium, so it's just excreted in the stool. But really, hyperkalemia, quite common in patients with CKD. It does involve a discussion of dietary potassium restriction, as well as sometimes the use of medications. Now we're going to talk about the generation of acid and acid balance as it relates to CKD. So look on the left. So in our diet, we take in proteins, and so basically from metabolizing amino acids and even nucleic acids from protein, we generate acid every day. We generate some hydrogen ion. And then also just from incomplete degradation of fats and carbohydrates, we'll produce some lactic acid and keto acids every day. And so the net effect of all this is accumulation of protons and a generation of a metabolic acidosis. And so what's the net effect of acid from our diet and then the lactate and keto acids? Well, it tends to be about 1 millimole per kilogram per day. This is just an estimate and could obviously vary for person to person based on their intake, but on average, a 70 kilogram person would generate about 70 millimoles of acid per day. And then also remember that you lose a little bit of bicarbonate in your stool. And so if you're losing a little bit of bicarbonate and you're generating acid, the net effect is that every day we have this tendency to develop a metabolic acidosis. But keep in mind, this is why we have the bicarbonate buffering system. So whatever acid we produce is going to get buffered by bicarbonate. Eventually that's going to be turned into carbon dioxide and water, so the water doesn't cause any problems, and the CO2, yes, it's a form of acid, but it's a volatile acid that we can just breathe off, so the lungs will take care of this. But overall, what's going to happen is that we're going to deplete our bicarbonate. This is going to decrease, and so this is where the kidney comes in. So the kidney does two important things. One thing it does is that since bicarbonate is filtered at the glomerulus, the kidney will reabsorb all of it. So this is going back to circulation. Otherwise, all that filtered bicarbonate would end up in the urine, and we would deplete our bicarbonate stores even further. Another important thing that the kidney does is essentially it takes CO2 and water, and it will split it into bicarbonate and a hydrogen ion. And so this is all done with the help of intracellular carbonic anhydrase, which is present in tubular cells lining the collecting duct. So if you think about it, the kidney is sort of doing the opposite of this reaction that we did earlier. It's taking CO2 water, and eventually we'll get a bicarbonate and a hydrogen ion. And what it does, this bicarbonate, it returns to the circulation, and then this hydrogen ion, it dumps it into the urine. And so in effect, what the kidney's doing, it's regenerating the bicarbonate that got chewed up during the buffering event that happened earlier. And at the same time, to make sure that we're not adding acid to the system, it makes sure that it pumps hydrogen ions into the urine, which goes out literally down the toilet. And so this is how our body, or how the kidney also regulates acid balance, because we have this tendency to develop a metabolic acidosis just from our diet and from metabolism. And this is how the kidney keeps up with it, by reclaiming all the filtered bicarbonate to make sure we don't lose any, and then by actually regenerating new bicarbonate that matches exactly one for one whatever bicarbonate we lost earlier in the day, and at the same time dumping hydrogen ions into the urine. So a few notes about why we care about treating metabolic acidosis. One, it's been shown that chronic metabolic acidosis is actually associated with worsening chronic kidney disease progression, as in the GFR will decline faster with uncontrolled metabolic acidosis than otherwise. And so we do know that treating metabolic acidosis and correcting it actually will slow CKD progression, which is huge. And then also chronic metabolic acidosis, because we're sort of depleting bicarbonate and we're unable to keep up, we actually begin to start buffering in bone. And so we can actually accelerate bone loss and bone mineral disease and worsening renal osteodystrophy due to a chronic metabolic acidosis, because we're sort of burning bone to try and help buffer for the chronic acidosis. So it's something we want to treat, and we can treat it. So the treatment of metabolic acidosis in the setting of CKD is quite simple. It's with alkali therapy. Basically, give them back the bicarbonate that they've lost. And so, what I'm saying here only applies to sort of stable outpatients who have a clear metabolic acidosis due to CKD, not lactic acidosis or DKA or anything like that. But a patient in clinic with stable metabolic acidosis can be treated successfully with either sodium bicarbonate or sodium citrate, which is basically going to get metabolized into bicarbonate. So a couple of side effects of these drugs. So sodium bicarbonate can cause some gastrointestinal bloating. Obviously it can cause some fluid retention as it contains sodium. In some of the trials where this was used to slow the progression of CKD, there was a non-statistically significant increase in fluid retention in patients who were taking sodium bicarbonate. Sodium citrate, you're supposed to avoid administering this with aluminum-containing antacids, as this can actually increase the gastrointestinal absorption of aluminum, which you definitely want to avoid. Okay, so what is the goal? Well, the goal is just to normalize the serum bicarbonate concentration. So that means bringing it back up to 23 to 29 milliequivalents per liter. So it's not uncommon for a patient with CKD, maybe the bicarbonate somewhere between, it could be as low as 12 all the way up to 21. And so these are the patients you certainly want to treat and manage with oral bicarbonate therapy. You just want to bring it back up to normal. And a good starting dose is somewhere between, half to 1 milliequivalent per kilogram per day. So think about it. You want to sort of replenish the low bicarbonate, and then you want to keep up with daily acid production. And so daily acid production should be somewhere around 1 milliequivalent per kilo per day. So when you're doing your dosing, it's important to know how much you're actually getting the patient. So for instance, if you're dosing sodium bicarbonate, the pills come in 650 milligram tablets. And so 650 milligrams of sodium bicarbonate is about 7.6 milliequivalents. And, I've had some people, if let's say you don't want to add another prescription, or maybe medications are quite costly, you can actually use Arm & Hammer baking soda. So about 1/8 of a teaspoon of baking soda is just under 7 milliequivalents. And so this is another way to administer sodium bicarbonate. Let's say if maybe they can't swallow pills, or they would rather not take the pill and they're okay sort of drinking a mixture of baking soda and water. But sort of having these numbers floating around, you can actually dose the medication appropriately, correct metabolic acidosis, and slow the progression of CKD. One thing I did leave off earlier, chronic metabolic acidosis also leads to muscle wasting and loss of muscle mass. And so correcting metabolic acidosis, like I said, can help bone disease, slow CKD progression, and also help build back up your muscles.